Welcome to our Antenatal Education Class. We hope that the following short videos and slides will help answer some of the questions you may have about the changes that happen to your body in pregnancy, the labour stages and pain relief, and what happens once the baby is born. This information will assist you to make birth choices in your birth plan. This generally happens around 34 to 36 weeks. Please speak to your community midwife for further details.
I'm Carolyn Lindsay. I'm one of the specialist physios in women's health, and today we're going to go through some exercises that can help your body to sort of adjust to the changes of pregnancy and also to try and prevent the onset of any back or pelvic girdle pain. So the first thing that we're going to think about standing posture and how that can have an impact on the development of symptoms and problems. So taking a look here at Lisa and how you're standing. So the first things that I notice are that your knees are quite locked out and straightened, and there's a bit of an arch here in your back. Your pelvis is tilted forward a little bit. So this can be associated with having the development of back pain because it puts your back joints under a little bit more strain. So in order to try and correct this, what I'd like you to try and do is not to completely loosen your knees, but just have your knees a little bit soft so they're not totally locked out. And then start to think about where you've got your weight. So does it feel like your weight's really far forward? Do you feel like your weight's really far back on your heels? Try and get a little bit of weight through your heels and then a bit of weight through the base of your big toe and the base of your little toe. And then you're thinking about getting some length up through your spine, so keeping your chin just soft, so don't lift from your chin, that's it. And think about just almost as though you're going to push my hand away with your head. So you're going to push down through your heels and get tall up through the top of my head. And what you feel then is you can feel that your abdominal muscles are just kicking in a little bit there. So if you go back into the posture that you were happy in, can you feel the difference there with your tummy? And then you're going to just slightly unlock your knees. Think about dipping your chin a bit, pushing up through here, down through your heels, and you can feel that already those muscles that we want to get working can kick in a little bit. So then thinking about the other type of posture that people might be in, so if you could just demonstrate for me, so a bit of a chin poke posture and hanging a bit on the hips. So this is the other posture that people will tend to adopt, where they hang on their hips and the head's a little bit forward, and this can be very associated with developing pelvic girdle pain. So again, all you need to do is try and again bring your pelvis back in line with your feet and think about your weight through your heels, base of your big toe, base of your little toe, and then chin soft, and you're gently stretching up again, thinking about elongating your spine. And as shown here, this needs to be quite a relaxed way of correcting, so you don't want to be holding everything really tight from your thoracic. And then those types of keeping on correcting your posture little and often can help kick in the muscles that we want to work and stop the development of problems later. Now we're going to have a little look at sitting posture and how that can make a difference as well. So looking here at Lisa's natural sitting posture, this is very common with most pregnant ladies and most of us in fact, that we tend to slump under here with the pelvis and then be quite rounded through here, and then with the chin and the head poking forward. So that actually puts quite a lot of strain onto your muscles here from having to hold your heavy head forwards, and also some strain on your lower back, and it's a more difficult position for moving out of for your pelvis as well. So to correct that, you're going to just gently think about your weight through your sit bones and think about pushing down there and gently coming up and forward. And it's very similar to correcting your standing posture, where you're keeping your chin a little bit soft and thinking about just getting up tall, pushing down through your sit bones and through the top of your head. So this should be quite a relaxed posture. You should still be able to move a little bit. You don't feel like you're bracing really hard with your thoracic, and it should feel fairly easy. But it's going to be difficult to maintain that posture, so you'll probably need to keep practicing little and often. So the other way that people can sit to sort of overcorrect when they're pregnant is to tilt the pelvis quite far forward. And again, you can see this puts quite a bit of strain across this area of your back here. So again, you're thinking about the pushing down through the sit bones and the top of your head and just coming up tall and then into that nice sitting posture. So then if we think about sit to stand, it's very common if you go back into your posture there and then have a stand up for us. And you can see that as Lisa stands up there, she locks her knees out and she's sort of standing back into that arch posture. So if you come and sit back down again, that's grand, thank you. And then this time you're going to think about keeping your chest up. So think about this part of your chest staying up and forward, and you're going to lean forwards and come up and not lock your knees out and stand up there. That's it, so a bit more actively. Okay, so that's a simple thing, but just a way that you can start to change your movement patterns and keep practicing that, and then that can make a difference and help your body to adapt a bit better. Looking at the gym ball here, a gym ball can be a really good thing to do some exercises on. If you're looking to buy one, then you want to get one where when you're sat on it and it's properly pumped up, your hips are slightly higher than your knees. You don't want your hips kind of level with your knees or lower than your knees, because that makes it awkward. So sitting on the ball, you can see that just sitting on the ball immediately starts to engage your muscles a little bit and improve your posture. And then there's a few exercises that you can do nicely on a ball to help with control around this area and also easing off any stiffness in your lower back. So very gently doing some pelvic tilts where you're going to tilt your pelvis gently forwards and then tilt all the way back and then back up forwards nice and gently. So you're not exaggerating the forwards movement too much, and you're thinking about control and gentle slow movement, and then you can feel that it kind of targets your core muscles here. That's lovely. So then the next one, thinking about doing a little bit of tilting side to side. So you're going to just tilt one side and then back over to the other side nice and slowly, and back over to the other side, okay, and back to the middle. That's it, lovely. And then this is also a good position where you can do your pelvic floor exercises as well. So doing your gentle lift up inside, which we've talked about in a different section. As your pregnancy progresses, your abdominal muscles are working very hard and stretching and lengthening. So it's very important to try and work these muscles as well as your pelvic floor. And a good position to do this in is on your hands and knees, if that's comfortable for you. So thinking about your position here, if you can bring your hands back a little bit just so that they're under your shoulders there, and you've got your knees under your hips, and then not too relaxed through here, so not like a saggy donkey, but just a little bit of straightness through here, and again just looking ahead of you there on the mat. So then, without letting your back sag, let your tummy just release and relax a little bit, and then you're thinking about drawing in with your pelvic floor muscles and a little bit as if you're trying to get your belly button back towards your spine, and still breathe normally and try and hold that for a few breaths, and then release down. Have a little rest, and then again, so looking just ahead of you there so your head's not holding up, you're going to gently, as you breathe out, draw in with those muscles and try and hold for a few breaths. That's lovely, and back down. So you'd be trying to do 10 of these, and you're aiming to hold for 10 seconds and do 10 of them, but for most people, holding for a couple of breaths and trying to do 10 of them to start with is more than enough. If your hands get uncomfortable in this position, you can make fists and actually go onto your fists, and that can be a little bit more comfortable. Or if that's a problem, you can also go onto a gym ball and lean forward over a ball to work this. But this is also a nice position to do a little bit of humping and hollowing to try and ease your lower back off and your middle back if you've got any strain there. So just humping up, hollowing down a little bit, and then back up again. And you can tuck your head under when you're doing that bit, that's lovely, and back down. The other position that can be quite nice is, especially if it's uncomfortable in that hands and knees position, is forward lean over a ball. And this is a nice position to relax in as well. But then in this position, you can also do your gentle draws in with your pelvic floor and your tummy. So trying to draw that in without moving your back too much, and hold for a few seconds and ease off. You can also do some tilting of tucking your bottom under you and tilting back the other way. And it's also quite a nice position to just do some general rocking around and movements to ease things off a little bit. These are some exercises that can help with rib flare and with any discomfort that you're getting in your middle back, and also with all of the changes that are happening related to the breast changes as well, where you can get some stiffness and discomfort in that middle back area. So thinking about doing some gentle rotations of your middle back, so with your arms gently crossed across your chest, and then you're just going to twist around to one way, back to the middle, and then back to the other way. So just nice and gently, not pushing into any pain, but just getting a little bit of movement there and back the other way. So you probably do about 5 or 10 of these at a time. Thank you. So then you're thinking about giving a bit more space for if you're getting any rib pain or rib flare, where you're going to think about lifting up and over with one arm. So keep your other arm down on the chair or just down beside you, and you're thinking about lifting up and over towards the opposite part of the ceiling. So you're lifting up and over to really elongate and stretch out down this side. So if you're doing it wrong, then you'll be more just crunching down, and you can see that there's not as much stretch here and it's a lot more compressed down this side. So again, thinking about lifting up and over towards the opposite ceiling of the wall just to give a good stretch down here. And again, you're looking at doing 5 to 10 of them just within your own tolerance. This exercise is a nice one to work your deep buttock muscles. So these are the muscles that keep your pelvis nice and level when you're walking or if you're standing on one leg. So if the muscles were weak, for example, and I stand on one leg, then your pelvis will tend to tip to one side. So obviously that's not as good for walking, and it can lead to the development of pain. If you come into side lying on a bed, you've got a pillow in between your knees for comfort, trying to keep your back nice and straight. Keep your heels together, your top hip slightly rolled forward, and then all you're going to do is gently lift your top knee, but without rolling back. So if you lift and roll back, you can see that Lisa's pelvis comes all the way back here, and then the right muscles aren't working. So you're trying to keep that hip forward and just gently lift a small way. Try and hold for a few seconds, back down, rest for a few seconds, and then repeat. So you're trying to do this, aiming for 10 times if you can. It can get a little bit uncomfortable into that buttock muscle, so you might want to start with only a few at a time and aiming to do 1 set every day if you can. One of the difficult things is getting comfortable at night, so especially if you've got any back or pelvic pain, it can really help to get some extra pillows into the bed and support in between your legs. But the important thing to think about with this is, if you can have your knees as bent up as your bump allows, that's actually more comfortable and takes some pressure off your pelvis. And also to use enough pillows so that actually your hip, your knee and your ankle are roughly parallel, rather than your knee being dropped forward. This can be more comfortable. And if you're a little bit further along and it helps as well, then a bit of support under your bump from a very thin towel or cushion can help. Another difficulty is getting out of bed. So Lisa gets up very similarly to how most pregnant ladies get out of bed, which is obviously quite difficult because your tummy muscles are stretched and not kicking in as much. They're not as efficient, and this is quite a straining way to get out of bed. So a way that can make things a bit easier are, if So if you've been lying still for quite a long time, actually doing a few pelvic tilts to just get your body moving a little bit, a few gentle pelvic floor squeezes to just wake things up, and then if you can shuffle a little bit more towards the edge of the bed, and then you're actually going to use the cantilever of your legs coming off and your body pushing up. So bring your knees both together up here, and then as your legs come down, you're pushing up, and then it's just a lot easier and a lot less strain on your body. Around 1 in 3 women have bladder problems in pregnancy. Your pelvic floor muscles can really help with this. They're the muscles that span the bottom of your pelvis, so they go from your pubic bone at the front to your tailbone at the back, and they're also what's supporting your inner organs, so your bladder, your bowels, your uterus, and also supporting the weight of your growing baby through the pregnancy. So it's really important that these muscles are strengthened up. There's an outer layer of muscles and then an inner, deeper layer of muscles, which are the ones that we're concerned with. So these muscles are called your levator ani muscles, which means pick up your anus, which gives a good clue as to how we're going to be working these muscles. And in fact, if you've ever seen a dog being told off and its tail goes up between its legs, that's because the pelvic floor's gone tight and those muscles are working. So trying to do these exercises, you can do them in sitting, lying, side lying. They're the best positions to start in. And so if you sat here in a nice posture with your feet flat on the floor, thinking about being in that nice upright posture, and then to work the muscles, you're thinking about where they are. So from your pubic bone to your tailbone, and as you squeeze those muscles, they're going to lift up and forwards. But it's a very gentle movement. So you're thinking about very gently pulling in from your back passage as if you're trying to stop wind. So you're trying to just gently clench and lift up and forward, and then think about drawing in more towards the front as if you're trying to hold in wee. But with all of that, you're trying to still keep breathing normally. So you don't want to be overusing any of the other muscles. So common things that you might notice are that you're squeezing quite hard with your buttocks, or you're holding quite tight around here. So relaxing everything else and just trying to think about that gentle lift up and in, only so much as you can keep breathing normally. And you might feel it in your lower tummy, but you shouldn't be feeling it any higher up. And everything's quite relaxed in your shoulders as well. So you're aiming to do repetitions of 10, so 10 of however many seconds you can hold. So to start with, that might only be a few breaths, it might only be 5 seconds holding, but it's important to do 10 of them, and then gradually build up to try and do 10-second holds and 10 of them. But you need to be aiming for 3 sets a day, so it's quite difficult to try and fit them in, but the regularity of it to try and work the muscles as much as you can. So then, as well as the slow ones, which are going to help build up the endurance of your muscles so that things will support more, you also want to be doing some quick contractions so that your muscle can kick in if you need them, if you're coughing or sneezing or doing something quickly. So for these, you're trying to pull in and release as quickly as you can, but ideally just feeling this again low down, everything's not happening here. So you're just going to pull in as much as you can without working your upper tummy too much. If you've been trying these exercises regularly for about 4 to 6 weeks and you're still finding it really difficult, or you're not seeing any progress, then it's worth asking your midwife or your health visitor if they can refer you, or your GP, to come and see physio so that we can assess you and give you a hand with this, because these exercises are really, really important, not just for pregnancy but throughout the rest of our lives as well. We're going to think about areas where we hold tension, and also some strategies to use breathing to help with relaxation and also through labour. Thinking about areas where we might hold tension, we might find that our shoulders are going up tight and raised, might be clenching the hands into fists, the jaw might be quite tight, or might be noticing that the pelvic floor is squeezed up tight, or the tummy. So it's worth just looking at your own body and thinking about what the reactions are if you become stressed or anxious now, before labour, so that you can watch out for some of those things. One way that's really good to think about is your breathing. So for nice relaxed breathing, if we think about the diaphragm, that's a dome-shaped muscle, sort of here. As you breathe in, your diaphragm moves down and flattens, and your tummy will gently rise as air comes in. And then as you breathe out, the opposite happens. Your diaphragm's moving back up, the air's going out, and your tummy's gently flattening. Now obviously in pregnancy, there's a lot more space taken up by the baby, and it does become more difficult to do this nice relaxed breathing, so it's good to start practicing this. So if you pop a hand just gently on your lower tummy there, and you're just focusing on your breathing in this area. So just nice relaxed breathing. As you breathe in, your tummy gently rises, and as you breathe out, your tummy gently falls. So there's not too much movement happening up here with a big breath, and you've just got the gentle movement of your tummy. So in the first stage of labour, in the early stages, that's really nice to start doing that nice relaxed breathing. And you can also get your partner to do a little bit of massage as well. So either just with the hands across this area, or you can use maybe a tennis ball or a little massage ball and roll it around to sort of help ease the muscles off here. And it's also a nice time to do some of that pelvic tilting and moving around. And then in labour as well, some women quite like a bit of gentle massage to this area. So you're just kind of going with what your partner likes and needs at the time. Annie's just joined us now, and we're going to talk through some breathing and relaxation through labour. So thinking about that late first stage of labour.
We just wanted to illustrate how very often women will breathe when they're in pain. They tend to tense up, they will clench their fists quite tight, and there'll be a lot of tension here. If you're breathing in this way, it's quite difficult for the neck of the womb to relax and open round the baby's head. So really, if you breathe nice and slowly, like Caroline is going to show you in a moment, you will be aiding your baby's journey through the birth canal.
So, as we're saying, with that fast, rapid, shallow breathing, that tends to make everything a lot more tense. So do a nice deep breath out slowly. So sigh your breath out slowly, and then relax your fists, and you're thinking about just that gentle breathing where your tummy is gently rising and falling. So as the surge of the contraction carries on, trying to do that nice relaxed breathing, and then towards the end of the contraction again, doing another sighing out slowly breath. So nice breath to sigh out slowly. And at any point through your labour, if you're feeling that tension building up and your breathing's becoming rapid and shallow, do this SOS breathing, or the sighing out slowly breathing, because that slow sigh out can help to relax and release. And then your partner's also looking for any areas where you might be holding any tension. So you can use this type of breathing through the second stage of labour as your baby's making its way down the birth canal, and just thinking about where you might be holding tension. So is your pelvic floor actually clenched really tight? Because obviously this needs to be released and relaxed. So trying to focus on letting tension go out of your shoulders, out of your hands, and letting your pelvic floor gently release. We've talked about areas where you hold tension, and now we're going to move on to other ways that you can help to relax these areas. So by tensing your muscles and then releasing and relaxing into a new position. So if we're thinking about your face and your jaw, if there's tension held there, so actually to try and release your jaw and open your jaw, but without opening your mouth, to give that a good stretch downwards, and then allow that to stop and just feel the new position of your jaw. So then you're going to again think about opening and stretching your jaw, but still keeping your mouth closed. Stop and feel that new position, and then you should feel that your things are feeling a little bit more released and relaxed. Think about the position of your tongue in your mouth. Does it feel like it's held right up against the roof of your mouth? can you allow it to just come down into the middle of your mouth? So then if you're thinking around your shoulders, do these shoulder muscles feel quite tense and tight? So in whichever position you're relaxing in, think about drawing those shoulders down. So you're thinking about pulling your shoulders down a little bit and holding, and then release, and feel the new position of your shoulders. So you're going to do that twice, and then moving around to think about your breathing again. So just that gentle, relaxed breathing, that as you breathe in, your tummy's gently rising, and as you breathe out, your tummy's gently relaxing back. So just to focus on that nice, slow, relaxed breath. Then if Lisa's going into a contraction or having a surge, you can see that her fists and her face are really clenched up and tight. So thinking about doing the opposite with the fingers. So really stretching your fingers out there, Lisa. Really stretch them hard out the other way, and then stop and let them just relax down. So you can do that a couple of times. Stretch your fingers out again really hard, and then stop and let them just relax onto the surface that they're on. And similarly, just trying to relax the lines on your face and ease your face back the other way, and then let it just relax down again. So become aware of where the ball is, where the ball's supporting your arms, supporting your hands, and then again bringing your attention back to your breath and to that nice gentle breathing, or if you need to doing one of the long slow sighs out. In a straightforward pregnancy, moderate regular exercise is good for you and the baby. If you have any medical conditions such as heart or breathing problems, poorly controlled diabetes, high or low blood pressure, or a low-lying placenta after 26 weeks, then you need to seek advice from your doctor before starting any exercise programme. The aim is to maintain or slightly improve your fitness by carrying out a moderate level of exercise to improve your cardiovascular fitness. Moderate exercise is where you could still carry on a conversation whilst exercising. The aim is that you're working up to the recommended level of 30 minutes of exercise 3 times a week. Gentle exercise is safe throughout pregnancy, but if you haven't exercised before, it's advisable to wait until after 13 weeks. If you already exercise regularly, you're fine to carry on. There are physical and psychological benefits of exercising, including maintaining your fitness, helping with healthy weight gain throughout your pregnancy, and improving balance, coordination and endurance. And it also helps you to be fit for your labour. The best types of activities are low-impact activities such as walking, swimming or aqua aerobics, Pilates or yoga, and non-contact sports without a risk of falling. There are local antenatal and postnatal activities run from both the Healthy Living Centre at Staveley and Queen's Park Leisure Centre. Things to be aware of are that your joints are slightly more lax, and where your centre of gravity is altered by your bump. So this makes it slightly more likely that you might go over on an ankle or lose your balance slightly. However, this is still very unlikely to happen, but just to be aware of. It's also important to keep hydrated whilst exercising and not to exercise to the point of fatigue when you're pregnant. From around 16 weeks, you need to avoid lying flat for any prolonged activity during exercise, because this can make you feel faint and unwell. Stop exercising and seek advice from your midwife or doctor if any of the following happen when you're exercising: any leaking of amniotic fluid, severe abdominal pain, vaginal bleeding, shortness of breath, dizziness or palpitations, or any severe calf pain or headache, or if you notice that your fetal movements or the movements of the baby are reduced or absent. If you're unsure about exercising in pregnancy or which types of exercise are suitable for you, then your midwife or doctor can refer you through to physiotherapy for an assessment.
Welcome to the antenatal classes at Chesterfield Royal Hospital. I'm Barbara Reid. I'm one of the community midwives attached to the hospital.
And my name's Carla Richards. I'm another community midwife attached to Chesterfield Royal.
Today I thought we'd look at the different stages of labour and start off by looking at when to go into labour when you're in hospital. A lot of women are quite concerned as to when to go in. Is it actually labour? What is happening? So we thought we'd start off by looking at some scenarios that would hopefully demonstrate if you are actually in labour and what you need to do. Okay, if we can have the first question then, Julie.
Joanne is getting backache. It seems to be coming and going every half an hour.
So do you think this might be it then, that she might be in labour?
She might be starting in labour, I think.
Yes, yeah, it could be the early stages of labour. Have you got any ideas what she should be doing?
A warm bath.
Yeah, a warm bath.
Some paracetamol.
Yeah, that's really good, yeah, both of those would help. I mean, this early stage of labour, things can take their time, but it does often start with a bit of backache or a bit of low period type pain. So yeah, just relax as much as you can. Warm baths, paracetamol would be very good.
And stay at home.
Stay at home, yeah. Okay, shall we have the next question then, Jill?
Jill has not felt the baby move all day.
Our advice would be, if she rang in and spoke to us, would be whatever normal pattern is for your baby's movements should stay that way right up until you have your baby. And it's different for every lady, so it's just whatever you're experiencing. If you're not happy that your baby's moving accordingly to what its normal pattern is, just sit somewhere quiet, have something hot, cold or sugar if you're allowed to, and then if that baby doesn't respond to that within a couple of hours, then you should be contacting your maternity unit. So just give Chesterfield a ring, and then you'll be able to discuss it with the midwife. But don't ignore any changes in behaviour.
Emma has just been to the toilet, and on the tissue she noticed some mucus with old blood stains in it.
So do you think that might be a sign of labour?
I don't think so, but it doesn't sound very nice.
No, probably isn't very nice. Does it look a bit sort of snotty and mucousy and sticky?
Yeah, it says mucousy and with blood in it.
With blood in it, okay. And was it bright red blood or was it
Old.
brown? Old, okay. So most likely what we call a show. And a show occurs when the cervix starts to change. These changes to the cervix take place towards the end of pregnancy in the last few weeks. And as the cervix starts to change and open slightly, you lose the mucus plug. And that can come away, it can be a week or two before labour, or it might not come away until labour, but it generally is sort of streaked either with old blood or a little bit of fresh red streaking in it. And if it is just a little bit, then we wouldn't worry, and there is nothing really that you need to do, and just carry on as normal.
As long as it's not itchy, it's not red fresh bleeding, and it's not offensive, then it's just something to keep an eye on.
Okay.
Yeah.
I guess following on from that, my question is, Diana's noticed some fresh blood in her pants, about 2 tablespoonfuls.
Any red fresh bleeding throughout your pregnancy, and it's not unusual, and some ladies will think it's part of a show, but any red fresh bleeding that looks like the beginning of a period that's not mucousy, then you should be reporting it to your maternity unit.
My question is, Angie is worried.
Okay, I mean, anything that you're worried about, phone either your community base or your maternity hospital, your maternity unit, and they will give you advice over the phone. What we don't want is for you to be sat at home worrying, because there's always advice available.
Where would we phone it at what time?
Okay, the community bases are up and running in most areas now, and they're open 8 till 4. Some of them are every day of the week, and some are not open Saturdays and Sundays, but there should be a sticker on the front of your notes that tells you sort of when they're closed and when they're closed for lunch and everything. Outside of those hours, the Pregnancy Assessment Centre, their number is on the front of your note, so it would be them that you need to phone. Okay.
Sarah just doesn't feel well. She has a thumping headache and her face and feet appear swollen.
Any signs and symptoms, pregnancy, particularly towards the end, is very stressful and it has a big impact on your systems. But anything unusual for your pregnancy, then you should raise it with either your community midwife at your base, or you can contact the hospital. And if it's not something that the community midwife can address, then she'll advise you what to do from there on. And just record any symptoms that you've got. And if it's just something, just check that, have you not eaten recently, or have you not had anything to drink? It could be big dehydration, low blood sugar, just an early pregnancy swelling is not unusual. So just talk to your midwife and then she'll be able to put your mind at rest, hopefully, or be able to refer you on if appropriate.
Ruth has had diarrhoea today.
Right, I mean, this could be several things. I mean, do you think it could be a sign of labour, or?
It could be. It can happen, can't it, when somebody goes into labour?
Yeah, that's right. I mean, a lot of ladies do sort of empty their bowels and have a good clear out before labour, and it's just the body preparing itself and sort of emptying the bowel so there's more room for the head to come down and everything in labour. So yeah, it could be a sign that she's about to go into labour any day. Could just be that she's picked up a bit of a stomach bug. So what we'd say is just to sort of keep an eye on things, make sure she stays well hydrated, and if it carries on over 24 hours, to contact one of the bases or even the GP, and they might talk to her about getting some extra fluids inside her.
Cindy is having strong period pains every 5 minutes.
That again is something just to keep an eye on. It's not unusual in early labour, and it's not unusual towards end of pregnancy. As long as the movements are all right, there's no fresh bleeding, and it's just monitor the effects of them. Are they long lasting? Are they quite painful? If it's just mild, it's just something to keep an eye on. As long as everything else is all right, as long as your movements, no bleeding, your waters aren't leaking, then it's just something to keep an eye on, and just talk to your midwife if you've got any concerns.
My question is, Sue's knickers are wet.
Right, so Sue's knickers are wet. So have you any idea what you think that could be?
I would think, if it was me, it would be my waters had maybe broken.
Yeah, I mean, that's obviously the first thing most people would think about. And at this stage, we're thinking that you've probably not got any contractions. You're at the end of your pregnancy. What colour? Does it say what colour it is or not?
No, it says the word.
Okay. Colour's very important when we're looking at your waters having gone. It should be a clear straw colour. If it's any darker than that, very dark yellow, if it's a green, browny colour, we need to know. The other thing we need to know about is any blood staining in the waters. So if it is clear, you still need to contact the hospital, but it's very important that you report to the midwives what colour it is and whether you're having contractions or not. Okay. If you're not having contractions, the hospital will leave you for about 24 hours to allow your labour to start naturally, and then if it's not started within that time, we need to think about inducing your labour and getting you going, because obviously a bag of waters is like a protective bag that the baby's in, and once those have gone, baby's more prone to catching an infection, so we just need to get your labour in. Okay?
Yep. Could it be that she's had a wee?
It could be that she's had a wee, yes, that's something else that we'd think about. So it might be that when you phone the hospital, the advice they give you is to put a pad on, see if you continue draining any fluid, because if it is your waters, you will continue to drain. Could just be towards the end of pregnancy that you are leaking a bit of fluid, because baby's sort of bouncing up and down on your bladder, and as it's doing that, a little bit of urine's leaking. So it could be that. And the other thing it is sometimes is a very clear discharge. You do get sort of a clear watery discharge towards the end of your pregnancy. Right. But any doubts, phone the hospital and they'll talk to you about what you need to do.
Okay.
Okay, thanks.
My scenario is Sarah just doesn't feel well. She has a thumping headache and her face and feet appear swollen.
If she doesn't feel unwell at all, she should be contacting either a community midwife to discuss it or contact your hospital. If it's a headache, if there's any visual disturbances, if you just don't feel right and you've got general swelling, then they're all important factors to note, particularly in late pregnancy or any stage of pregnancy really. You should be contacting somebody if you're not feeling well yourself and getting advice, and then we can get you checked over. It could be linked to blood pressure problems. It could just be that you're getting towards the end of your pregnancy. It could be linked to, if you're not eating properly or drinking, but we need to make the distinction and just check that you're well and happy to continue.
Is this what they call preeclampsia?
It potentially could be, yeah, but don't worry about it. It's just something that we watch out for, particularly in first-time mums, but not in everybody. It's just something you just need to note if you're just generally feeling unwell, any swelling, general swelling, any particularly visual disturbances, persistent headaches that won't go with a bit of rest and some paracetamol. And if it's different for you, if it's different for your pregnancy and not what you used to expect it, then yeah, speak to a midwife.
Kirsty has been having regular pains and the hospital have told her to stay at home for a while. They feel a lot stronger now and she's a bit frightened by this.
Okay, so obviously she's going to be very frightened. It's probably her first pregnancy. It's something that she doesn't know what to expect and that she's not experienced before. By phoning the hospital and talking to them, the hospital do get a very good idea of how she's coping and if it's time for her to go into the hospital or not. If she's been at home a little while, since she last spoke to the hospital and the pains are getting stronger, then it might be an idea that she needs to phone back. A lot of women phone when the contractions are sort of every 5 minutes. Quite a few women at that stage, they'll be told to stay at home, that they're perhaps not ready to go in. A good time is when the contractions are sort of 2 to 3 contractions every 10 minutes or about 3 to 4 minutes apart, just to give your body time to get established and your labour to get established. But as long as baby's active, she's no bleeding, and she's been in regular contact with the hospital and they've told her to stay at home, that's fine. If she feels that she needs to speak to them again, then that's what she needs to do.
Claire's woken at 5 a.m. with backache and tummy ache and the bed's soaking wet.
Again, what is the potential? What might be happening to her?
I think the waters might have gone, or that she might have had a wee in the night.
Yeah, there's no hard and fast rules, and everybody's different. Everybody will experience these things differently, and they can go with a gush, they can go with a trickle, or you can just be a little bit damp. So if you're in any doubt at all, just pop a pad on and then speak to your hospital, and just be aware of the colour and just any other things that aren't quite right at the time. If you anything unusual for your pregnancy. But you should always contact the hospital because they need to pinpoint if they are your waters that they have gone, and we can make a plan for inducing you should we need to.
Will they make her go straight into the hospital then at this point?
I would have thought so, yeah, at that stage. She pop a pad on so we can see exactly what you're losing when you get there, and then we'll always speak to the hospital before you go, let them be prepared. And then they can just observe things when you get there, and they can tell you, let us make that distinction of whether your waters have gone or not, and then we can make a plan for you.
Can I just ask how would is there things that they can do to be able to help if you're a bit unsure sometimes? What things might they be able to look at if you are unsure whether the waters have gone or not?
The procedure once you get to hospital?
Yeah.
If we'll get you sitting down for a little while and do what we call pooling. You'll hear it's a common term, and just get you sitting there just for a little while, and then we can have. If it's not an obvious thing, with some girls, we know it's there. They're leaking lots of fluid. We know it's the waters that have probably gone, and if everything else is all right, then we know we can just make a plan. If with any doubt at all, we'll do what we call a speculum examination, where we'll have a little look with a little instrument, and we'll guide you through it. It's an unusual thing to have to do, especially when you're not labouring, but it's an important thing to do, that we do confirm whether your waters have gone or not. And even if at that time we suspect they haven't, if it does happen again, you just contact us again, because just because we don't see it at that time, it just means that we've not seen any fluid at that time. So then we would, if it does happen to you again, just ring the hospital again and just say it's a second episode, and we can follow it up.
Julie has a strong, sharp and severe pain in her upper tummy, and it isn't going away.
Okay, so do you think that sounds like a normal contraction or labour pain might, from what you're
Not if it's there all the time. If it's not going away, I don't think that would be normal.
Normally, if it's a contraction, it would sort of start, get a bit stronger, and then relax off a bit. So the fact that it's there all the time and the tummy feels quite tense, did you say?
Severe pains.
Severe pains, yeah, and a lot of pain there. I don't think we could think of this as being a contraction. It could just be that she's perhaps had a little bit of bleeding near the placenta, and that it needs checking out. So that is often associated with quite sharp pain, so she needs to phone the hospital as soon as possible. It might be that she has a bit of bleeding associated with it, or it may be that there isn't any visible. So
Gaviscon won't cure this.
No.
I would definitely.
It's not necessarily means there's a problem there. It just means that it's something different. If it's a sharp pain, any pain unusual for your pregnancy, you should discuss it with somebody, and then we can best advise you as to what path to follow.
Anybody else got any questions, or
I think that's it.
We've finished. So I guess to summarise, hopefully we've given you a bit of an idea of when you might need to contact the hospital and when to go in labour. The main things as far as labour concerned are your waters going, or if you think your waters have gone, when you're getting contractions maybe 4 or 5 minutes apart, any bleeding, any concerns about movements, they're the main issues. But just any worries, if you're not feeling well, please contact one of the bases or the hospital.
Thank you.
The following slides will guide you through why staying active during your labour is important and show you useful coping strategies to use whilst at home or hospital. Normal labour starts between 37 and 42 weeks. There are different stages in your labour. Early or latent first stage. You may experience contractions that do not settle into a pattern. These may be painful, and you could start several days before labour begins. You may have a show, or your mortars may break. Your cervix will soften, thin and start to dilate. If you need reassurance, please contact your community midwife, midwifery base, pregnancy assessment or birth centre. Once labour is fully established, it is, for most women, over within 12 to 24 hours. Active first stage. The contractions will now be regular, equally spaced out, and of similar or increased strength to the contraction before. The cervix or neck of the womb softens and opens until it is wide enough, 10 centimetres, for your baby to move down into your vagina, the birth canal. Second stage. This is the pushing part of your labour. Your baby will move down your vagina and out into the world. This may last up to 2 hours for a first baby. Third stage. The placenta and membranes peel away from the uterus or womb and come out of your vagina. We use several aromatherapy oils at Chesterfield, and your community midwife may have already introduced you to some. Only use what your midwife has given you, as these oils will have the desired therapeutic effect. You may continue to use these at home, either in the bath, as a massage, or inhalation, depending on what blends she has prepared for you. Staying calm and doing your deep breathing is really important during your contractions, as you need to provide the baby and the uterus with oxygen. Build up your endorphins, which are natural painkillers, and oxytocin, the hormone that will get through the labour. Take each contraction as it comes and forget about the time. Keeping calm and focused will help you reduce stress levels and the negative effects that adrenaline can have on the labour. Follow your instincts and move around. Change positions or have a nap in between. Do what feels right. You cannot rush this process even if you try. Have good birth support from your partner, relative, or even a friend. They will help keep you relaxed, hydrated, and nourished. You will need calories for your labour to progress. If there is a clinical reason why you should not eat, your midwife will inform you of this. Remain positive. Each contraction is one closer to holding your baby. Soft lighting, music, and comfortable clothing will help you keep calm and relaxed. Familiar things and surroundings also help keep adrenaline low and stimulate the release of endorphins and oxytocin. We have different aids to help you keep in the best positions for your labour to progress. Keep your visitors to a minimum to help you remain focused. Your birthing support will give you encouragement and keep you focused on how well you are doing. If you could be doing something differently, they'll make suggestions too. They may keep you hydrated and nourished, so having a goodie bag with different drinks, snacks, or even sweets is often helpful. They may offer you massage, comfort, and support, as well as keeping you positive in your journey to parenthood. Your midwife will encourage them to work as a team. Whilst you remain active and mobile, gravity will assist the contractions, so you will have two powerful forces helping birth your baby. The pelvic joints will remain free to move and expand, giving the baby as much room as there is available, encouraging an easier journey through the pelvis. The placental flow and oxygen to the baby improves as there are no restrictions from the heavy uterus. Your labour may be shorter and consequently the need for pain relief will be reduced. It gives you control and confidence in your body's ability to birth a baby. In the next 3 slides, we are going to explore how the 3 P's work together: the passenger, your baby, positions, and your pelvis. Ideally, your baby is well flexed with his or her chin tucked on its chest, down in the pelvis, and in anterior position with his or her back at the front of your tummy. The bones in the skull overlap and make the diameter of the head smaller. If your baby is deflexed, the chin is not tucked on its chest, or posterior, its back is on your back, he or she will need time to rotate, and opting for an upright, forward position will help aid this. Ask your midwife for further information. The following slides show you different positions you may adopt to make birthing a little easier. Try one or try them all. Your body will tell you what feels right at the time. You can increase the capacity of your pelvis by 28% just by changing to different positions. The shape of the pelvis directs the baby to the outlet, so the more room your baby has to maneuver into the world, the easier the journey will be. There are different hormones that allow your pelvis to expand, and you may have noticed your pelvis becoming uncomfortable towards the end of your pregnancy as this process takes hold. Remember to keep your pelvis open to maximize what room there is available for your baby to be born. Essential oils can be used to reduce stress and relieve pain. There are several oils available and they can be used in different ways. For example, inhaled, in a bath, or as a massage. Please ask your community midwife for further information as these oils can be used from 37 weeks onwards. Massage is brilliant for reducing tension and comforting you. It can be done anywhere, your shoulders, your back, your tummy, your feet, or even your hands. A tennis ball provides even pressure, particularly on the shoulders, helping reduce tension and keeping you relaxed and focused. TENS stands for Transcutaneous Electrical Nerve Stimulation, and it works by sending electrical pulses via 4 pads placed on your back. It builds up high levels of endorphins, which are pain-killing chemicals. You will need to hire it through your local pharmacy or via the internet, but remember to ask for one that is suitable for labour, i.e. 4 pads. TENS is very effective in the early stages of labour. It cannot be used in water, but you may combine it with other forms of pain relief. For further information, please ask your community midwife. There are 4 pools at Chesterfield Birth Centre. You may find the water soothing during your labour, and relaxing in deep, warm water both supports your weight and alleviates the pain. A warm shower can help ease lower back pain, particularly early in your labour. If you are interested in the pool, please ask your community midwife to discuss suitability with you. Entonox is commonly known as gas and air or laughing gas. You breathe it in through a mouthpiece. It will encourage you to remain focused on your breathing and taking deep breaths in. It is easy to use and you remain in control, but it is important to only breathe it in with a contraction. It may make you feel dizzy, giggly, and high. Some people feel sick, but labour in itself can make you feel this way, regardless of the form of pain relief you choose. The effects are short-lasting, so when you stop breathing it in, it stops within 30 to 40 seconds. It does not relieve the pain entirely, but you may use it with other forms of pain relief, for example, in the pool. Pethidine is given into your thigh by injection. It can make you feel sleepy, relaxed, lightheaded, or sick. This may make you want to lie down. Remember that labour in itself may make you feel sick. It does not relieve the pain entirely, but it will make it easier to manage. This form of pain relief will cross through the placenta and may make the baby a little sleepy to feed effectively. Epidural is carried out by an anaesthetist. An injection of local anaesthetic and painkiller is given into the epidural space in your back through a fine tube called a catheter. This is then topped up as you feel you need it. You will also have a drip of fluid running. This is to keep you hydrated and to counteract any side effects from the epidural. Epidural can drop your blood pressure, and this form of pain relief may be recommended to you if yours has been high during your pregnancy. Your baby's heartbeat will be monitored continuously, as any sudden drop in blood pressure may also drop the baby's heartbeat. The midwife looking after you will deal with this if it happens. The aim of an epidural is to block the pain from the contractions while still being able to move your legs. When your baby is ready to be born, you will be aware of your contractions to help you with pushing. You can have an epidural once your labour is established. If your legs get heavy, you may be confined to the bed. This may slow your labour down. It also increases your chances of needing assistance for the birth, for example, ventouse or forceps. Epidural does not have any effect on the baby once he or she is born.
Hello, I'm Julie Sykes, Community Midwife at Chesterfield Royal Hospital.
And I'm Jane Ragg. I'm also a midwife at Chesterfield Royal Hospital as well.
What we're going to talk about today is how the baby passes through the pelvis in labour and the options that you as mums have regarding pain relief and the choices that you can make while you're in hospital.
And I'm going to talk a little bit about what the actual functions of the pelvis and with the baby passing through the pelvis, how important that is really in how it can influence the outcomes of when the labour starts with that. So obviously this is the pelvis and it's quite a rigid structure, as you can see, but our pelvises are more flexible than this because they've got ligaments in between, and you've got your tailbone, your coccyx as it's better known on there, and I'll come back to that in a little bit because that can make a huge difference. Before labour starts, when you come to antenatal clinic and we're doing the palpations, the baby is above this is called the symphysis pubis here, and that joins together the pelvis in the middle, and that's why a lot of ladies towards the end of the pregnancy get a lot of discomfort as well, because if you imagine you've got the baby, you've got the placenta, you've got the waters, and everything in that, and all of that is pressing on that structure, making a difference there. So when you come to clinic, we write cephalic free, and that actually means that the baby's head is still above the bony structure of the pelvis there, and when we do the palpation through your tummy, you can actually still move the head. And then as towards the end of the pregnancy, what happens is the baby starts to actually go into the pelvis, and so you can see there, it's common sense that you can see that you can only feel a little bit of the baby's head. The function of a contraction is actually to open up the cervix, but also to help the baby, assist the baby through the pelvis. So when you get a contraction, that's exactly what's happening. So even though it seems like quite a short journey here, obviously you've got a sling of pelvic floor muscles underneath your pelvis. It's not just like an open cavity like it is here. So the baby's got to come through those pelvic floor muscles there, and that's why it's a longer journey than it seems when labour starts. So when you get a contraction, and during the first stage of labour, that's when you're going to have to do all the coping strategies that Julie's going to talk about in a minute, and that we're going to do with the game with that. But the contraction will make the baby, every baby starts off in a different position before labour, and what we want actually is that the baby's back will be at the front of your tummy, so you've got a nice rounded shape like that. It'll be tucked in like this. And then some babies start off that actually their back's more to the side, or some babies actually start off that their back's more to the back of your tummy. And if you hear the term like baby's back to back or posterior position, that's important not to panic when you hear that, because some babies may not be able to turn all the way round, but assistance can be given to do that. But most babies, even though it might take a little bit longer in your labour, actually they'll make that journey quite nicely round to the front. So if you hear a midwife say that it's back to back position, don't freak out about that really. But if we can just demonstrate that what we would want is that most babies have got their back to the front, that means that the baby's head is actually really nicely flexed onto the cervix, and it's giving a better chance of the cervix dilating there with that. And then the reason why we try to promote more of an upright position as well when labour starts is because if you can imagine, if you're laid flat on your back, which you do still see on the TV version sometimes, but if you've got a baby that's in a different position like we just talked about, then that's not giving that baby the best chance of coming through the pelvis. So if you can imagine, if you're laid flat on the back, you'll see that the coccyx is like tipping slightly inwards like that. So if you've got a baby that needs maximum room, you've already limited those diameters, haven't you? Whereas if you're more in an upright position, the coccyx can then tip backwards, and then you're giving baby the better chance of coming through the pelvis with that. So that's the reason why we're trying to talk more about being in a better position for labour starting.
Your uterus is a muscular sac that sits very nicely in your pelvis, and normally it's the size of a small pear, but it has to grow. When it grows throughout your pregnancy, we measure you every time you have an antenatal appointment. It's a muscular sac that works, and it needs to be nourished to work, so bear that in mind as well when you are in labour, to keep well hydrated, eating and drinking regularly. It's a sac that's full of muscle, ligaments. It's got a very, very good supply. And during labour, this uterus will contract every 3 to 4 minutes and regularly. What we're going to look at now is the different choices of pain relief that are available at Chesterfield Royal Hospital and at most hospitals. We've also got some cards which I'd like you to look at, read out and place where you think are appropriate on which particular choice of pain relief is available. Hi Angela, how are you feeling?
I'm just a bit tired, but I'm okay, thanks.
Yeah. Oh, you've had about an hour's skin to skin now. Shall I pop her back in your cot so we can see how you are?
Are you going to weigh her?
Yeah, we're going to weigh her and measure her, and I'll go through all that with you.
All right, thanks.
Is that okay?
Yeah.
Oh, come on then, Fiona.
Just put my shirt.
She's lovely. Hello. Let's just pop her on here. I'll pop her in. Are you okay there?
Yeah, I'm fine, thanks.
Angela, we're just going to measure her and everything. Is that okay?
Yeah.
She's nice and warm and she's lovely and dry. Just going to measure her head. We've got, 35 centimetres. And then we're just measuring her. Oh, hello. 52.
She's quite long, isn't she?
Yeah, she's lovely. Hello, just having a quick look at her. These two soft spots on her head will close. The one at the front will close after about 18 months, but the one at the back, little fontanelle, will close more or less straight away. Okay. So you've moulded to come through. Let's have a little look at you. We'll have a proper look at her in a minute. Let's just see how much you weigh. £7.6. Did you want to just have a little look to check that? Oh yes. Okay. You were quite happy for her to have a vitamin K injection. She might cry a little bit, but there we go. That's it. Well done. Okay. All right. And this clamp will stay on a cord, and the cord will drop off probably after about a week or so. We don't need to do anything with that. Just make sure it's kept relatively clean.
Don't have to clean it with anything.
No, you don't have to do anything. It'll get a little bit smelly and then it'll drop off. I'm just going to put some name bracelets on, Angela. Do you want to just check those? Check it. And then we'll pop them on, and they need to stay on all the time she's in hospital. If any of those drop off while she's in hospital, just let a member of staff know, because we like them both to stay on all the time that you're in. Just going to pop her a nappy on. Just let us know when she's weed and pooed, and when she's poos it'll be that black tarry meconium, and we'll be asking her about the nappies a lot. Is that okay?
Yep.
Let's put you, then you can go back to mummy. Her eyes look pretty dark, but her eye colour will change, and she'll be the colour that they'll be the colour that they need to be by about 6 weeks.
Okay.
And they can see pretty well, but the vision's probably developed by about 3 months, when the rods and cones in their eyes are fully formed. All right. Right then, let's have a little look at you. Back to mummy. We always encourage that all babies stay in hospital with mum by her bedside. Mums and dads are given a lot of help and advice and emotional support while they're in hospital to gain confidence with looking after the babies. This includes help being given to change nappies, feeding demonstrations, if they are bottle feeding, lots of help with breastfeeding, and also being shown how to bathe the baby. We do encourage that all babies are bathed in plain water. While baby's in hospital, he or she will have a hearing screening done and a full neonatal examination from a qualified member of staff. We also ensure that all babies are safe and secure. We do stick to a visiting policy, and we always ensure that all babies have a security tag on their ankle just to provide an extra measure of safety. If any baby goes near a door where he or she shouldn't be, that will set an alarm off. Okay. Have a little cuddle with your baby, Angela. Just have a little rest now, and make sure you have a drink and let me know when you need anything. You've got your buzzer there, and I'll be back in a few minutes, and then we'll soon transfer you up to the ward.
Okay.
All right.
Yeah, thanks.
Hello, I'm Kate. I'm a carrying consultant trained with the Slinger Baby Training School, member of the British Association of Baby Wearing Instructors, and I help to run a sling library, which means I spend a lot of time helping parents and carers to carry their children from tiny newborns all the way to big toddlers safely in slings and carriers. I've been asked to make this film by Chesterfield Royal Hospital to show clear information about how to use carriers safely with a newborn baby. Babies like to be held, they feel loved and secure close to the caregiver. When the baby's close to you, they can feel your warmth, they can hear your heartbeat, they can feel the rhythm of your breathing, they can smell you, all the things that they're used to. This comforts them and helps them feel secure. It's an opportunity for any parent or carer to be close to the baby, and this can really help in the development of long-term relationships, in attachment, and again, helping the baby feel secure and helping the parent feel confident with handling. Finally, it's convenient. It's really great for you because you can walk the dog, you can go shopping, you can do all the things that a pram makes it difficult to do. There's a huge selection of slings and carriers available, from simple pieces of cloth to complex multi-position carriers costing hundreds and hundreds of pounds. To keep it really simple, I'm going to call them all carriers. Just like any baby carrier, be it a Moses basket, a car seat, a crib, a swing, slings and carriers can be used safely and they can be used unsafely. So our objective is to carry as if in arms, but with your hands free, supporting your baby safely in their natural position with an appropriate carrier. We need to support the baby against gravity and against flop, and to do this we need to fit the carrier to their natural position. Don't think about it as popping a baby into a carrier, but rather think about it as moulding a carrier around a baby. So from the parent's point of view, the natural carrying position, which we're going to try and aim for, is upright on the chest, baby facing parent. From the baby's point of view, their natural position tends to be with the knees bent and the hips flexed, hips not overspread, back supported in its natural curve, and the hands available. In the carrier, we want to see the baby in a deep squat, knees high, bum low, hips open but not overspread. We want to see the back supported in its natural curve, we want the hands available, we want the feet free, we want the head in line with the spine and the face visible with free airflow to it. There are other safe positions, but these need to be taught carefully in order that they should be safe, and there are also unsafe positions such as cradle or slump. Both of these can give a risk of suffocation. The most important safety consideration is airway. In order to avoid any airway compromise, and that means risk of suffocation, we need to be able to see the baby's face at all times. We need free flow of air to the face. We need to make sure the baby's chin is not on their chest, and we need to make sure the baby's not slumped to either side or down like this. Another very important safety consideration is temperature. So when you add layers of carrier, that's like adding layers of clothing. So you need to make sure your baby doesn't overheat, dress them appropriately. In thin layers is best. Take a cardigan or a jacket, pop it in your changing bag and pop it onto the baby when you take them out of the carrier. If it's hot or windy or wet or cold, you need to protect them. So you need to protect their feet, hands and head from the sun, from the wind and from anything else. Positioning. The sling must support baby in a way that is appropriate to their age, size and level of head and trunk control. Hydration. A tiny baby can sleep for hours in a sling or carrier. Is that baby drinking often enough, and are you drinking often enough? Finally, the sling or carrier itself. It needs to be comfortable for both the baby and for the wearer. It needs to be of reputable manufacture, of good quality, in good repair. It needs to be age and size appropriate. It needs to be dyed with child-friendly dyes. The TICS rules for safe baby wearing have been produced by the UK Sling Consortium and are widely used by carrier manufacturers and carrying professionals across the UK. The carrier should be tight, we don't want the baby falling out. The baby's face should be in view at all times, we want that baby breathing. The baby should be close enough to kiss, we want you monitoring and interacting with that baby. We need to keep the chin off the chest, we want that baby breathing, and finally, we need to keep the back supported in its natural developmental curve. Let's look at some examples of carriers that can be used straight from birth. The first one I want to look at is the stretchy wrap. This is a length of soft, stretchy material which is wound around the carer and then moulded around the baby to give a lovely soft supported position. Tying the stretchy can seem complicated at first. Once you've been shown how to do it a couple of times, it becomes as easy as collapsing your pram. There's quite a lot of difference in thickness, in stretchiness between the brands of stretchy wrap, so it's really well worth trying a few to see which one's right for you. Soft, stretchy fabric wraps around the carer so one size fits all. It fits snugly around the baby to support them in their natural position. You can tie on once and pop baby in and out easily all day. I'm going to talk about the structured stretchy now. The best known brand of these is the Close Caboo. It's made of soft fabric and it's tightened through rings at the side. Some people find these easier and more comfortable than a stretchy wrap. Other people find them harder and less comfortable. It's really a case of trying one and seeing how you get on. The structured stretchy carrier is of soft stretchy construction, wraps around the carer and is tightened and loosened through rings at the side. When it's tightened correctly, it fits snugly around the baby to support them in their natural position. You loosen it to take the baby out and re-tighten when you put the baby back in. A ring sling is a length of fabric with 2 rings sewn into the end, and it's used around the body to support the baby in a hammock, carefully tightened through the rings to support the natural position. There's a bit of a knack to using a ring sling, but once you've mastered it, you can use it from newborn right through to toddlerhood and beyond. Again, they come in lots of different fabrics and lots of different constructions, so it's well worth trying a few before buying anything. A ring sling is a length of fabric with a pair of rings sewn into one end. There's a knack to using them, but once mastered, it can be used from birth to as old as you like. You loosen to take the baby out, and you re-tighten when you put the baby back in. The last option I'm going to talk about is the May tie. This is a rectangle of fabric with straps that tie around the waist and straps that tie around the body to support the baby. There's a very wide range of May tie styles available. Generally, the adjustable styles with wide straps are best for very young babies. The May tie is a panel of fabric with straps that tie around the baby and the carer. There's a very wide range. Adjustable styles with wide wrap straps support the young baby best. You untie completely to take the baby out and re-tie when you put the baby back in. There are other carriers that can be used safely from birth, and there are also carriers that claim to be safe from birth but actually need modification in order to make them safe. Your local sling library or carrying consultant will be able to go through the options I've shown you today and also look at other options so that you can find something that's going to work well for you and your baby and your lifestyle. In Chesterfield and the local area, your local sling library is Chesterfield Sling Library. You can look us up on Facebook for details of session days, times and locations, and message us with any questions you have. Your local carrying consultant is me. You can find me on Facebook as Ways to Carry or contact me directly by email, kate@waystocarry.co.uk. If you don't live in or near Chesterfield, you can find your nearest sling library or carrying consultant at www.slingpages.co.uk. I hope you found this information useful and that you now have a good understanding of the things you need to take into consideration from a safety point of view when using slings or carriers with your baby or young child. Thanks very much.
Hello, my name is Sarah Petty and I'm the Senior Matron for Maternity Outpatients. We hope that you've enjoyed the parent education video and that you've found it useful and beneficial. We're always looking for new and innovative ways to get information out to women. If you have any suggestions or you would like to talk to a midwife about anything that you've seen in the parent education video, then please contact your midwife at the community midwifery bases that they are linked to.